I'd like to start by thanking our funders and the CRAFT committee for supporting this research. So I'm Zoe Klemfuss. I'm faculty in the Department of Psychological Science here at UCI. And the work I'm discussing today is a new collaboration with my colleague Tepet Yates at UC Riverside. And our primary goal of this work is to identify target intervention points to improve acceptance of and adherence to public health behavioral guidelines in order to reduce the spread of the virus. And our particular emphasis is on adolescents and caregivers from historically marginalized populations. So at present, adherence to recommended health behaviors, which we're all quite familiar with at this point, is the best available strategy to reduce the spread of COVID-19. And thus our ability to reduce spread is dependent on every, or at least most individuals' acceptance of and adherence to these behaviors. So as such, it's crucial to understand which factors may impede or promote acceptance and adherence to develop effective interventions to then reduce the spread. So research, as Dan mentioned, is still quite limited about the extent to which children and teens may be contributing to the spread of the virus. But youth do appear to be less symptomatic than adults. And extensive pre-pandemic research has demonstrated that engagement in risky health behaviors peaks in adolescence, and that specifically in adolescence, these behaviors are exacerbated by stress, which they're probably experiencing quite a bit of right now. So as such, adolescents may be particularly likely to eschew public health recommendations, perhaps risking further spread of the virus. And this risk may be particularly dangerous in communities of color and of low SES, given documented disparities in COVID transmission and mortality rates in these populations. So in light of these concerns, our overarching aims are to identify pre-COVID and contemporaneous factors that predict engagement in risky health behaviors in a sociodemographically diverse sample of adolescents and their caregivers. We're also interested in testing the mediating role, or the potential mediating role, of adolescent and caregiver perceptions of risk and seriousness of COVID-19 in these associations. So this is a partial list of the very many pre-pandemic individual, family, and community level factors that we expect will predict pandemic-related perceptions and health behaviors by way of perceptions of risk and seriousness of COVID-19. So on the left side of the slide are pre-COVID-19 factors that we've already collected across numerous waves of pre-COVID data collection. On the right side of the slide are contemporaneous factors that we're assessing via 4 additional waves of data collection funded by the current grant. So one of the key innovations of the current proposal is the extent and richness of that pre-COVID data set. We're drawing from a sample of 250 families who've been involved in Dr. Yates's longitudinal study of health and well-being for over a decade at this point, with a target of recruiting between 150 and 200 of those dyads for the current studies. So to date, they've already completed 8 waves of data collection pre-pandemic. The first wave was when children were 4 years old, and children are now approximately 15. So notably, the project has had a remarkable 96% retention rate across those 10 years of waves. So the sample originated in the Riverside area. There's been quite a bit of spread in the last 10 years, but it is representative of the diversity of the area in terms of both race and ethnicity. However, the poverty rate in our sample is higher than in the surrounding community by design, so we're interested in SCS. So the ongoing longitudinal study has been paused due to the pandemic, which has allowed us to insert the present COVID-specific data waves. We plan to leverage the findings from the present study to apply for further funding for additional waves of data collection relevant to the pandemic until we're able to resume an already funded wave of in-person data collection post-pandemic. So the current grant will fund 2 waves of survey data collection and 2 waves of phone interviews that are being conducted by trained doctoral student interviewers. The surveys are administered electronically and separately to the caregivers and to the adolescents. And the phone interviews are coordinated by my doctoral student, M. Morehouse, who's conveniently the former project coordinator of the larger longitudinal project. So at each wave, adolescents and caregivers are interviewed separately and in parallel, and are then prompted through a joint conversation about the pandemic in order to assess parenting factors and the direction of pandemic-related information flow between the caregiver and the adolescent. In the surveys, we're assessing all of the contemporaneous predictors of interest. We're also assessing perceptions of risk and seriousness of COVID and adherence to CDC guidelines. And importantly, the youths are reporting on their own adherence. We're also asking the parents to report on their perceptions of the youth's adherence. We're also assessing the caregivers and the adolescents' tendency towards socially desirable responding to use as a control measure, since this is all self-report. In the interviews, we're gathering richer details regarding family-level predictors, perceptions of risk and seriousness, and adherence to recommendations. So through this approach, and by capitalizing on over 10 years of rich pre-existing longitudinal data, we hope to identify potential intervention targets to increase preventative behaviors and decrease risky behaviors amongst adolescents and their caregivers from diverse sociodemographic backgrounds in order to do our part to help slow the spread of COVID-19. So I want to thank our funders again and the funding committee, and thank you for your attention during this presentation. That's it. I'm open for questions.
Okay, thank you very much. So Zoe, do you want to make a prediction as to whether this will affect your longitudinal study in the sense that healthcare attitudes will be, or healthcare interest will be stronger and people will be more compliant with guidelines, if I understood the nature of the longitudinal study?
I'm not sure I understand the question. Could you repeat?
So I'm trying, I guess, to put a positive spin on some of this.
Yes.
Do you think that the experience of these people going through your study for COVID will influence outcomes in the longitudinal study so that you'll see a difference within the cohort that went through your COVID study in terms of their interest in healthcare and paying attention to guidance?
I understand. Yeah, so I guess from a social and moral perspective, yes, I very much hope so. And I do somewhat expect it, partially because as part of the study, we are exposing them to additional information, credible information about the pandemic. And in fact, we're testing their knowledge of the pandemic at each time point to see whether they've sort of learned some of the information that we're trying to disseminate. So we'll have those data about whether their knowledge of appropriate health behaviors and about the pandemic in general has shifted over time. And that'll sort of help us understand sort of whether their medical trust or adherence to medical best practices will have shifted in the larger longitudinal project.
Yeah, well, I wish you luck with the IRB, and we'll
really
we're
cleared. You're cleared.
Oh, you are? Okay.
We're interviewing right now.
Oh, good. Okay.